Hi, this is Dr. Poole with another Chalk Talk. This is the second part of the case vertigo, and I'm going to talk about edema, herniation, and hydrocephalus. These are three general patterns of injury. They're not specific to any disease, but demonstrate our first wading into some more specific brain lesions. As an introduction, remember the brain and the spinal cord are encased by bone, by the skull and the bony spinal canal respectively. And so the brain does not have much space to expand. And so generalized brain edema, increased CSF volume or hydrocephalus, and focally expanding mass lesions produce the consequences of edema, herniation, and hydrocephalus. So let's start talking about brain edema. Cerebral edema, or more precisely, edema involving the brain parenchyma, is the result of increased fluid leakage from the blood vessels or injury to various cells of the CNS. It can be generalized or localized, and the consequences of brain edema are elevation of intracranial pressure, which can affect the flow of blood throughout the brain, or directly cause cellular injury, and ultimately, which I'll talk about later, herniation of the brain through these rigid structures. There are two main pathways of edema formation in the brain: vasogenic edema and cytotoxic edema. There's a third pathway, which is interstitial edema. Vasogenic edema is an increase in extracellular fluid that's caused by disruption of the blood-brain barrier and increased vascular permeability, and this allows shift of fluid from the intravascular compartment into the intercellular spaces of the brain. The brain does not have a very developed lymphatic system, and so this greatly impairs resorption of excess extracellular fluid. Cytotoxic edema is an increase in intracellular fluid that's secondary to injury to neurons, glial cells, or endothelial cells in the brain vasculature. This is due to a failure of cell membranes, specifically the sodium-potassium pump, which leads to the accumulation of intracellular sodium and thus water, which follows the flow of sodium out of cells. Finally, interstitial edema or hydrocephalic edema is a minor pathway which generally is limited to the brain parenchyma around lateral ventricles, and this occurs when there's an increase in intravascular pressure, which causes abnormal flow of fluid from the interventricular CSF across the ependymal lining to the periventricular white matter. Again, this is a minor, uncommon cause of brain edema. So what this looks like grossly is indicated by the external view of the brain beneath the meninges, in which the gyri are widened and flattened because of the accumulation of edema fluid in the parenchyma, and an example is shown by the asterisk here, and conversely the narrowed sulci indicated by the diamond. So the sulci are compressed tightly together because of these swollen gyri. This is a coronal section of the brain showing marked compression of the lateral ventricles, indicated by the red triangle, and flattening of the gyri, an example showing by the white triangle, from extensive bilateral or generalized cerebral edema. The patient in this example was mountain climbing and ignored symptoms of a persistent worsening headache. The hypoxia from altitude led to endothelial damage with an increase in generalized intracellular edema or cytotoxic edema. In contrast, the mechanism of vasogenic edema again results from disruption of the blood-brain barrier, from inflammation, neoplasia, or generalized ischemia. But oftentimes these two forms overlap. In either case, edema increases intracranial pressure and increases the risk for herniation, which I'll talk about in a little bit. This is another coronal section of brain in which the left hemisphere is markedly enlarged compared to the right, and there's marked expansion of the white matter. This is the type of edema that's typically associated with a mass effect, commonly either primary or secondary or metastatic brain tumors. Herniation is defined by displacement of brain tissue past rigid boundaries. These boundaries include the falx, the tentorium, and the base of the skull or foramen magnum. This can be due to any space-occupying lesion, which leads to increased intracranial pressure, and then herniation of brain tissue through these rigid structures. The result is increased intracranial pressure and arterial compromise of the blood vessels that are trapped beneath these rigid structures, which then can result in ischemia, hemorrhage, and necrosis. There's three types of herniation, which are based upon the anatomic location of the herniation and the structures, the rigid structures that are involved in impinging the brain tissue. So there's subfalcine, which involve the falx, and the area of the brain which herniates is typically the cingulate gyrus. Transtentorial involves the tentorium, and the brain that's typically herniated is the mesial temporal lobe or uncinate part of the temporal lobe. And then finally there's tonsillar herniation, which involves herniation of one or both cerebellar tonsils through the foramen magnum. So I'll talk about these in a little bit more detail and show you some nice pictures. Subfalcine or cingulate herniation occurs when there's unilateral or asymmetric expansion of a cerebral hemisphere that displaces the cingulate gyrus underneath the falx. This can lead to compromise of the anterior cerebral artery and its branches. Here's an example of a subdural hemorrhage indicated by the blue arrow, which displaces the hemisphere medially, and there's herniation of the cingulate gyrus indicated by the red circle underneath the falx, which is indicated by the yellow arrow. Transtentorial herniation occurs when the medial aspect of the temporal lobe is compressed against or herniates underneath the free edge of the tentorium. This can result in compromise of the third cranial nerve, which results in pupillary dilation or impairment of ocular movements on the side of the herniation. It can also result in compromise of the posterior cerebral artery and the consequences which result from that. So this is a gross photograph from the inferior aspect of the brain showing the medial temporal lobe or uncinate herniating underneath the tentorium. That's indicated by the black triangle there. Note that there is resulting compromise and compression of the left side of the midbrain. The medial temporal lobe is pushed beneath the tentorium. This can occur either by a mass effect or from edema on the ipsilateral side of the brain. Impingement, again, of the cranial nerves can occur, particularly cranial nerve 3. Medial temporal lobe or uncinate herniation can cause bleeding into the pons, which is known as Duret hemorrhages, or if you prefer the French, Duret hemorrhages. When the herniated tissue pushes the brainstem further down into the posterior fossa, it stretches the perforating vessels into the pons and midbrain, and then you get this secondary brainstem bleeding. Note the deep groove on the right medial temporal lobe, indicated by the red down triangle caused by pressure against the tentorium. When there's a marked degree of herniation, you can get hemiparesis ipsilateral to the site of herniation, caused by compression of the contralateral cerebral peduncle. Finally, tonsillar herniation refers to displacement of the cerebellar tonsils through the foramen magnum. This is a life-threatening form of herniation, although none of them are exactly what you would want to get. But this is particularly devastating because of compromise of vital, respiratory, and cardiac regulatory centers in the medulla. Acute brain swelling above the tentorium or within the posterior fossa can force the posterior fossa contents downward or inferiorly toward the foramen magnum, and this can result in herniation of the cerebellar tonsils into the foramen magnum. Note the conical shape of these cerebellar tonsils around the medulla, indicated by the white triangle. Compression of the medulla then can result in compromise of the brainstem centers controlling respiration and cardiac activity, leading to death. This is an image of unilateral tonsillar herniation, indicated by the red circle, and the green arrows indicate the line of herniation through the foramen magnum. So the herniation indicated by red would be projecting through the foramen magnum toward you, the viewer. The blue circle indicates the brainstem. And one of the consequences, because of compromise of the vessels traveling alongside the herniated tissue, is brainstem infarct. Obviously, this would be a devastating injury. The final topic is hydrocephalus, or hydrocephalus if you prefer. This results from accumulation of excessive CSF within the ventricular system. The vast majority of time, this is due to some impairment of flow or resorption of CSF. Rarely, it can be due to overproduction, typically due to a tumor of the choroid plexus. The accumulation of fluid within the ventricular system results in elevation of intracranial pressure and all the consequences that occur because of that. Hydrocephalus can be distinguished into non-communicating or obstructive hydrocephalus, or communicating. In non-communicating, there's some kind of obstruction to the ventricular system, and it does not communicate with the subarachnoid space. These are frequently due to tumor. In communicating hydrocephalus, the ventricular system remains in communication with the subarachnoid space. Most commonly, again, this is due to some interference with resorption, which can be due, for example, to long-term complication of infections such as basilar meningitis. which leads to scarring that interferes with resorption or obstructs CSF outflow through the foramina of Luschka and Magenti. Or, again, rarely this could be due to overproduction from a choroid plexus tumor. So this is just a gross image showing marked dilation of the lateral ventricles. So hopefully with this introduction to cellular injury in the CSF and the general forms of injury of cerebral edema, herniation, and hydrocephalus, you feel much more comfortable and have a blissful state approaching the rest of neuropathology. So I hope you're feeling like Ron looks here. Thanks.